Leaving behind eating disorders, we're now going to turn our attention to the anxiety disorders, another one of the major classes of disorders that you're going to see. We're going to talk about anxiety disorders in general just for a moment, but your main job here is the differential diagnosis among the anxiety disorders, and then just some small differences in terms of how we're going to do treatment. Usually in these questions you can read them and tell us an anxiety disorder. That's fairly easy, but you have to drill down to know which anxiety disorder we're talking about. To set up our discussion, I want you to notice that anxiety disorders are the most common psychiatric disorder in women of any age. If all you know is a woman has a psychiatric disorder, your best guess, it's an anxiety disorder. For men, the problem is substance abuse. So this is easy to remember. Women get anxious, men do drugs. Now, you also have to be sensitive and think more broadly when focusing on anxiety disorders, because a number of the symptoms of anxiety disorders can mimic cardiovascular problems, including sometimes even an MI. So when you're looking at some of the symptomatology, you have to assure yourself that it is an anxiety disorder, not masking some underlying cardiovascular problem. I also remind you that anxiety is in some very real sense a self-generating spiral. You get CNS arousal, which feeds into some pathomimetic symptoms, which then goes back to CNS arousal, and it's not only self-perpetuating but escalating over time. Our interventions for anxiety disorders are usually trying to stop that escalating loop. The first of our anxiety disorders is GAD, generalized anxiety disorder. In order to be diagnosed with generalized anxiety disorder, you need to have anxiety more often than not over a 6-month period. Could there be a whole month where you don't have any anxiety? Absolutely yes, as long as there's a month and a day when you have total anxiety. The issue here, said differently, is that anxiety is the baseline of life for this person. There may be some relief, but the baseline, the most common state they find themselves in, is anxiety. The reason for these clear, definitive terms is, well, anxiety is a universal human emotion. Literally, everybody gets anxious, sometimes every day or every other day. We don't want to give the diagnosis to people just whenever they have anxiety. It's a disorder when it doesn't go away. Transitory states, that's fine. Things that are enduring, those are where we begin to talk about a disorder. I remind you that many people find they have more anxiety in situations that are less structured. If it's a Sunday afternoon without any work, without any particular activity scheduled, people may begin to suffer from more anxiety than when they're at work or doing structured activities. How do you know someone's having this anxiety? Well, the symptoms are pretty classic here, fairly easily understood. We have motor tension. The person's fidgety, jumpy, having a hard time sitting or standing still. There's autonomic hyperactivity. You feel your heart, gasping for breath, profuse sweating perhaps. There's cognitively fear, worry, apprehension, just ideas you can't really get out of your head, and vigilance and scanning. Paradoxically, people with anxiety notice peripheral cues in the environment, things most of the rest of us would miss. What they can't do is focus. What they can't do is bring their attention and focus on the job at hand. They're easily distracted by everything in the environment. It's a state of hypervigilance looking for something that might be intruding. Fatigue and sleep disturbances are common symptoms, and this is why most people with anxiety disorders come to see physicians. As people get more educated in our society, people are starting to come into physicians saying, I have anxiety, but more often, doc, I'm tired, I can't sleep, which is why I reminded you, people complaining of insomnia, you must make a clear decision. Is insomnia the problem, or is it a symptom of some underlying problem? One of the common underlying problems, of course, would be generalized anxiety disorder. Leaving GAD behind, let's move on to talk about phobias.
And substance-related anxiety. So the first disorder we're going to talk about is panic disorder. And this is an anxiety disorder which is characterized by recurrent and unexpected panic attacks. And in addition to having the attacks, they must also have a month of a concern about future attacks. So they're constantly worried they're going to have another attack. They have to worry that they are going crazy or that they're going to die. And it has to cause a significant change in their behavior related to the attacks. generally these attacks also should come out of the blue. Shouldn't be precipitated by something. In some cases they are, but most cases of panic disorder, the attacks will just come out of the blue. As with all psychiatric disorders, these symptoms must not be due to substances or a general medical condition. Panic disorder affects about 2% of the population, and most commonly in females, and usually they present in about their 20s. Agoraphobia is a little bit more common. It's at about 2 or 6% of the population. Again, more common in women, and may occur with or without concurrent panic disorder. And what agoraphobia is they're fearful of being in open spaces, and they're fearful of open spaces because they fear that they can't get out. What is the differential of panic disorder? You should differentiate it from any other kind of medical illnesses, such as thyroid problems. If you have diabetes, are you having a hypoglycemic episode? Are you using any other drugs or substances, such as cocaine, amphetamines? Make sure that those are not the causes of your panic disorder. Also want to make sure that it's not due to some other kind of mental illness, such as psychosis or obsessive compulsive disorder. Panic disorder may be present with agoraphobia, or it may present without it. And when you code for it and when you diagnose it, you just have to add panic disorder with agoraphobia or panic disorder with. This will come to phobic disorders, which are the most common types of psychiatric illnesses in our population. And it's an anxiety where the patients have intense fear over specific situations or things, and this is what's called a specific phobia. And it's an irrational fear. Now, social phobia is different from a specific phobia, as people are very fearful of a public or social setting, and the main important feature of social phobia is the fear of humiliation or embarrassment. So that must be present for you to have social phobia, is the fear of humiliation or embarrassment. And it can occur in many situations or a certain situation that doesn't have to be specific, but the humiliation or embarrassment is the most specific. And exposure to the specific source of anxiety must elicit the anxiety reaction, and fear and avoidance of the feared source should cause functional impairment. Again, specific phobias are the most common psychiatric disorder, about a lifetime prevalence of about 25%, women more than men, and generally occurs in childhood. It starts in childhood, most often before the age of 25. Differential diagnosis of phobic disorders, you want to rule out other mental disorders of anxiety, such as school anxiety or separation anxiety. Want to rule out any medical causes, any substance-related causes. And the management of phobic disorders will usually be cognitive behavioral therapy. If it's very, very severe, then you can use serotonin reuptake inhibitors or benzodiazepines, Buspar, or MAOIs. Obsessive compulsive disorder. So obsessive compulsive disorder is the presence of intrusive thoughts. So these are obsessive thoughts that the patient cannot get out of their head. And in order to relieve this anxiety, they have peculiar behaviors or compulsions to relieve the anxiety is obsessive compulsive disorder. And frequent obsessions include fears of contamination, being unsafe, aggression, sin, crime. And common compulsions include checking, locking, hand washing, counting in their head, praying. And the reason why this becomes a problem is because the worrying about the obsessions and carrying out the compulsions takes up a lot of time and causes significant distress. Also, a patient with obsessive compulsive disorder will say, "Doc, I know what I'm doing is crazy. I know that these thoughts are just not making sense. I don't know why I have to do them, but I just can't stop doing them." So that's a very important point about obsessive compulsive disorder. Again, you want to rule this out with someone who's psychotic, because a person with psychotic will be dead sure that whatever they're doing is because their hands are really dirty or because the doorknob is really dirty and they will get an illness. They won't be able to say, "Hey doc, I know what I'm seeing is not true, but I can't get it out of my head." They'll say, "No, this is really true." It's a delusion, so it'll be a fixed false belief. So with a person with obsessive compulsive disorder, look for someone in their late teens or their early 20s who have waxing and waning symptoms of obsessive and intrusive thoughts. They are associated with compulsive activities. And also remember that depression and substance abuse are frequent comorbidities with obsessive-compulsive disorder. Clomipramine, which is a tricyclic antidepressant, has the most serotonergic activity out of the tricyclic antidepressants. That can be helpful, as well as the serotonin reuptake inhibitors, in particular fluvoxamine. Exposure and response prevention is also very helpful. And other behavioral therapies that are helpful are relaxation training, systematic desensitization, and modeling. Now we'll take a break for anxiety disorders for behavioral science and psychiatry for Falcon Physician Reviews. Now we'll take a break for anxiety disorders for behavioral science and psychiatry for Falcon.
Panic disorder is next. Panic disorder is diagnosed only when the patient has 3 panic attacks in a 3-week period. Do that again. 3 in 3 is the key criterion. So, could I have panic attacks and not have a panic disorder? Absolutely yes. And please notice, if I have 12 panic attacks a year, 1 every month, although that's an issue, it's not a panic disorder. It simply doesn't match criterion for the diagnosis. You have to have your panic attacks with no clear circumscribed stimulus. If every time I see a dog I have a panic attack, well, that's a specific phobia. And that's actually a pretty good way to think about a panic disorder. It's a phobic response without a phobic object. Now think what that means to the patient. At least if I have a dog phobia, I know stay away from dogs and I won't have this reaction. But if I have a panic disorder, there's no stimulus, at least I'm aware of, that's providing a trigger here. And so there's more of a sense of being out of control, more of a sense of not understanding what's happening or where things are coming from. A panic attack is abrupt. It's not something that builds over the course of days or weeks. You feel fine and then bang, you're at this peak physiological arousal, certainly within 10 minutes, but often even sooner. You don't see it coming. As one patient with panic disorder once said to me, "Doc, it's like I'm walking down the street feeling good and somebody walks out and whacks me in the head with a 2x4. And again, I never saw it coming." How do you recognize somebody's having a panic attack? It's fairly easy. It's a fairly dramatic event. There's overwhelming fear and apprehension, a great terror of something awful that's going to happen or has happened. You have palpitations, trembling, sweating profusely, the racing heart. We're talking about extraordinary autonomic arousal, along with the conviction you're about to die or go crazy on the spot. You feel out of control and you just feel like you're spinning. You don't know where it's going to end. Often there's an air hunger, a hyperventilation where the person says, where's the air? Where the hell's the air? They feel like somehow they're in space, all the air has been sucked out. And while they're having this extraordinary physiological set of events, the people around them are sitting there calmly and quietly. You feel like you're in a little bubble, somebody once said to me, like you've been transported to an alternative universe, your sense of unreality, not sharing the reality of the people around you. Premenstrual period is a time of heightened vulnerability for people that get panic attacks. If you're someone who's subject to panic attack, the period, week or so right before the onset of menses, is the time you're more likely to experience them. Onset of panic disorder must be in the early 20s. This is not one of those disorders that you might develop in middle age or as an elderly patient. Point prevalence about just over 1% of the population. More important, lifetime prevalence roughly 4% of the population. The majority of people with panic disorder are women. Now, it's not exclusive to women, but the majority are women. So on your exam, I'd be looking for the presentation to be with a woman. Note that a fairly good number of cardiac patients also have these panic disorder problems. And I remind you, these physiological eruption of the panic attack along with the underlying vulnerability of cardiac problems is not a very good combination. These recurrent panic attacks, out of the blue, you don't see it coming, leave patients frightened, demoralized, hypochondriacal, agoraphobic, outright depressed. And again, it's a good place now to mention the overlap once more between panic and agoraphobia. The way you're going to do the differential when you see both is by history. Which came first? Do you have agoraphobia, where when the person tries to go out, they decompose into a panic attack? Or do they go out feeling good and have repeated panic attacks which punish them so they no longer want to go out, trying to pull inward and avoid these panic attacks that are uncontrollable? You have to decide which came first in order to nail the differential. Treatment for panic disorder, we have some very effective ones. The most effective is probably alprazolam. You have to give this drug not just as long as the panic attacks are there, but usually we give this prophylactically for 6 to 12 months, even after we haven't had any more panic attacks. For some patients, imipramine can be used effectively. Clonazepam is also used effectively. We throw SSRIs at everything, so go ahead and try that here. But I also want to point out you can use carbon dioxide either to trigger that panic attack moment or to reduce the intensity of the panic attack. Here's a really, I hope you find, easy question. You're flying over the United States. You're somewhere over the state of Nebraska. At that moment, the person sitting beside you in the airline seat has this full-blown panic attack, heart racing, sweating profusely. What should you do? Well, you should get out the airline vomit bag and have them breathe in and out of the bag. This will, because of the carbon dioxide, help them re-regulate their pulmonary, their breathing function. Remember, carbon dioxide is how we know when to breathe and when to not breathe. And that's the anxiety disorders. I want to remind you once again, your key exam issue here is not just to recognize you have an anxiety disorder, but which anxiety disorder. As for most of the DSM-IV, the criterion are clear and straightforward. Your job is to know it when you see it and be able to say which one of the subtypes you're looking at.